Okay, it's 9 o'clock, so I'm going to go ahead and get started. Welcome, everyone, and thank you for participating in the Pebbles of Hope inaugural webinar series commemorating National Prematurity Awareness Month. I'm Cheryl Major, and I'm the Executive Director of Pebbles of Hope. Many of you have signed up for multiple sessions, but for those of you that don't know, we will be hosting a total of 4 sessions during the month of November, all covering topics related to preemie nutrition, and this is our second session. The Pebbles of Hope mission is to help premature babies thrive through parent education, and this webinar series is the first step towards achieving that goal. To learn more about the organization and our activities, please visit our website at www.pebblesofhope.org. We really appreciate your support and hope that you will find this an informative session. I'm delighted to introduce to you our speaker for today. Cheryl Major has enjoyed a long-standing career as a board-certified neonatal nurse at Monroe Carroll Jr. Children's Hospital at Vanderbilt in Nashville, Tennessee, and she currently serves as a senior associate at the Department of Pediatrics at Vanderbilt University School of Medicine. She also serves as an adjunct instructor in nursing at Vanderbilt University School of Nursing. In 1981, Cheryl was appointed as a neonatal outreach educator and coordinator for the Tennessee Perinatal Regionalization Program, which encompasses medical and nursing continuing education, neonatal skills labs, and regional neonatal resuscitation provider and instructor courses for over 40 hospitals, a role she continues to hold today. Over the course of her 45 career in Tennessee, Major has received numerous awards on the local, state, and national level in the field of maternal child health. In 2010, she received the Pediatric Nurse of the Year Award from the March of Dimes Music City Division, and she received the March of Dimes National Advocacy and Government Affairs Appreciation Award in 2014. Cheryl is a regular teacher, researcher, and author on neonatal medicine, and currently serves on the board of directors of the Music City Division of the March of Dimes. Cheryl received her bachelor's degree in nursing with honors in 1968 from Skidmore College in Saratoga Springs, New York. Before we get started, I just have a couple of housekeeping matters to address. All attendees will be muted for the duration of the session, but during the presentation or after the presentation, you will have the opportunity to submit questions. Just type them into the chat box that you see on your screen. I will then read out the questions to Cheryl, who will answer them as time allows. With that, I will hand it over to Cheryl.
Well, thank you, Cheryl, and good morning, everyone. I am privileged to be asked to speak on this important subject today, and as you saw from the flyer or when you registered, I hope to give you an overview of the development of the GI system during pregnancy, what is undeveloped when the baby is born prematurely, what clinical problems can interfere with feeding, and what is best to feed the baby, and of course the benefits of breast milk, which we know is the ideal feeding for a baby. Ways that we can feed babies when they're in the neonatal intensive care unit. And throughout the presentation, I hope if we have some parents on the call that I can help you identify situations that will come up related to feeding and what you may hear discussed with you about your baby's progress. So the title we have is Understanding the Implications of the Premature Gut. So the first slide we have here is an illustration of the fetus during the first trimester of pregnancy. And I was attracted to this photograph because of the fact that it began to show us what is able to be seen in development at that early stage of pregnancy. And you see as you go down the highlighted areas, you see that we have the intestine. A thing for us to keep in mind that's our challenge when we're working with premature babies is that ideally this baby would have not been born, would have been inside the uterus, would have been supported by the mother and the placenta, and by the umbilical circulation would be getting the nutrition that they need to grow and develop. So our challenge in the NICU is to try to simulate as best as we can that ideal nutrition. And we've made a lot of progress, but we still are not completely able to substitute for that ideal maternal, placental, umbilical circulation. Also, I thought it would be good for us to just clarify when we talk about the gut or the GI tract, what exactly we're talking about. So this is a slide of the complete GI tract, And I've also just added that, of course, it starts with the mouth. So, again, when the baby is feeding, they swallow, and again, the feeding passes into the esophagus. There is a sphincter that actually then allows the milk to go into the stomach. Then there's a pyloric valve that enters then the feeding into the duodenum, and then you have the rest of the small intestine, the jejunum and the ileum. And the ileum is where there's another important valve that connects to the ascending colon, the transverse colon, and here you have the descending colon feeding into the rectum and then ultimately the anus from which the baby is able to stool. So this is a lot of development. And one of the things we've learned to appreciate is that sometimes things don't develop normally, but even when they do develop normally, there is a process of reaching that complete development. So things that often come up that we will again refer to as we go through some of the challenges is the sphincter function. When we talk about the esophageal sphincter, the pyloric sphincter, when we talk about the valves, peristalsis is the way that feeding moves through the GI tract. Digestion must occur, and then there has to be absorption into the bloodstream so that the nutrients can make their way into the circulation. So in the next couple of slides, I was just really in preparing fascinated by what has been discovered as far as the stage of fetal development of different parts or processes in the GI tract. And again, I just like to highlight a couple of those, but you'll have these in the slides to refer to following the call as well. But beginning as early as the 4th week of gestation, we have the development of the GI tract. And the stomach and intestines are completely formed by about 20 weeks gestation. Now that's the anatomy. When we get into the function, then of course that you will see will take a little bit more time. Intestines double in length in the last 15 weeks of gestation to an ultimate 275 centimeters at term. So it's a very long tube and series of the GI tract that must develop by term. The intestinal absorptive cells form as early as 9 weeks gestation, and endocrine and immune functions begin early. So that's what's needed for the digestion and for the ability to provide the nutrients that are needed for growth and development. So again, that process begins early, but again, it has to become more sophisticated as the fetal period progresses. Taste buds form between 7 and 12 weeks gestation, so even the fetus has a sensation of taste. And I haven't said it, but I want to mention it now, that prior to birth, babies are swallowing the amniotic fluid. And so this is where that is part of the stimulation for growth and development, but that also then allows the baby to begin to, with the development of something like taste buds, to be able to understand what is normal and to develop that sense of taste. Now, reflexes are very important to the process of digestion and feeding and normal GI function. So, again, they have found that at about 9.5 weeks, the mouth is opening in response to perioral stimulation. That at 11.5 weeks, the head is turning toward that stimulus. So, again, on ultrasound, you'll see that the baby has their hands up toward their face. And actually, again, as pregnancy progresses, they've seen babies actually sucking on their hand or their finger. At 10 to 12 weeks, swallowing is beginning, and that is going to help regulate the quantity of amniotic fluid that's surrounding the baby. And at 20 weeks, they've observed that the baby is actually sucking. And by 34 to 35 weeks, this is when we hopefully will see the coordination of sucking, swallowing, and breathing. Just a few more things that I just wanted to identify was that the pylorus, as I pointed out, which is the valve that connects the stomach to the duodenum, again, is there, and the fundus of the stomach and gastric glands by about 14 weeks gestation. The esophageal sphincter that is needed to pass the food from the esophagus into the stomach by about 28 weeks. And the anatomy that we've been talking about resembles term by about 20 weeks, as I had said before. One of the things that I want to identify and highlight here is the stomach, or the gastric capacity, is about 30 ml at term. So during fetal life, with swallowing, with growth, the stomach begins to grow and has a capacity at term at about 30 ml. And of course, when babies are feeding after birth, the stomach capacity will increase. But again, you know then that a premature baby born prior to term is going to have a gastric capacity that's less than that. There's a limited production of digestive enzymes and growth factors that are needed. Again, and by 28 weeks, biochemical and physiologic ability for limited digestion and absorption is expected. So you can see by 28 weeks, we have a biochemical and physiologic ability for limited digestion and absorption. Briefly, again, I just want to highlight here some additional things, but for digestion, we need gut-regulating polypeptides that regulate growth and development in the gut. We need transport of the protein, the glucose, and the fats. And we need enzymes. And this just gives you a little bit more detail about when those activities are expected to be present. So with that background, I think you can appreciate that when babies are born prematurely, things are at different stage of immaturity. So when we talk about risk factors, this is a slide to just highlight what are the things that the clinicians are having to take into consideration about the baby's ability to feed and meet their nutritional requirements. So the first set of information has to do with the baby's gestational age. And of course, prematurity is defined as a gestation less than 37 weeks. And then we have subsets of prematurity that make the baby even more preterm or more immature. So 34 to 36 weeks is categorized as late preterm, less than 32 weeks, very preterm, and less than 28 weeks, extremely preterm. So these are terms that sometimes in conversation, when clinicians are talking to the parents, you may hear them refer to your baby with those terms as a way to clarify what they feel the degree of prematurity is. Also, the birth weight. Of course, if the baby is born prematurely, they have not had enough time to grow. So another way of looking at risk factors is looking at the baby's weight. So if the baby's less than 1,500 grams, that's considered very low birth weight. If the baby's less than 1,000 grams, the baby's considered extremely low birth weight. And less than 750, again, we have different ways of expressing, but this is a very extremely premature baby. And so I think you can imagine that if we have that basic information about a baby, that we already know from that the risk factor that this baby is going to have an immature gut, is going to have more challenges with feeding, and we have to have different strategies to try to safely be able to provide the nutrition that the baby needs. Another two things that I thought I would bring up as far as risk factors is intrauterine growth restriction, or sometimes called IUGR, or when the baby's examined and is measured and plotted on a growth trough, is smaller than they should be for their gestational age. Now, sometimes this might be a problem that means that the baby will not have achieved the nutritional development or the developmental progress that they should have because there has been some placental insufficiency. But sometimes we have found that there can be an advantage to being intrauterine growth restricted because of the stress, so that's a variable that can be, again, something that might promote more steroid production, more advanced maturation of the GI tract. So each baby might be a little different if they are assessed as being intrauterine growth restricted. Also, large for gestational age babies means that they are larger than they should be for that gestational age. And we're beginning to see more of this, especially with the increase in diabetes during pregnancy. So this could be another risk factor, because if the baby has grown larger than expected, one of the things that may have caused this is the baby has hyperinsulinemia. The pancreas is putting out more insulin, and that's promoting the baby's growth. And then when the baby is born, this increased insulin is going to make the babies at risk for low blood sugar. So this is another factor that's going to definitely affect the baby's need for fluid, for glucose intake to prevent them from having hypoglycemia. And of course, their overall clinical condition that we're going to talk about next is another major risk factor as to when and how we can feed these babies. So what are some of the clinical problems that are associated with prematurity? One of the things, of course, we know is that when babies are born prematurely and then have to breathe on their own, there can be complications with their initiation of breathing at birth. And with that, they can then have some bradycardia. So APGAR scores, as you know, is a way of scoring the baby at 1 and 5 minutes of age, and that is usually then an indication of the degree of distress the baby had. And depending upon the distress, there may be a need for the baby to have resuscitation, help with breathing, help with maintaining their heart rate, help with getting their oxygen level up, etc. So a maximal APGAR is 10, and the lowest APGAR is 0. So the thing we worry about is if there is a low APGAR score and there is a need for resuscitation, that means that there is the possibility that the baby didn't get enough oxygen to the cells of the GI tract, that there may have not been adequate circulation to the GI tract. And when there is that kind of injury to the GI tract, it's going to take some time for it to heal and for the surface of the gut and for the tissues to repair so that they can then be able to process the food, digest the food, and have peristalsis, etc. So that's a risk factor that's going to affect when and how the baby would be fed. Apnea and bradycardia is a complication of prematurity that, again, is because of their immature brain and the center that controls their breathing. And so that can be a factor, again, if it's frequent, that could affect their ability to have normal GI function. So if that's treated and the baby is recovering, then there's time for healing, and then the baby would be able to tolerate the feeding better. Sepsis or infection of the bloodstream is something that we know is often associated with premature labor. It also could be something that can affect the baby in the nursery. And so when they have infection, that obviously is a system-wide problem. And so the GI tract can be affected by that. So they need to be treated for the sepsis, and the antibiotics that they're given for that might also have an impact on their GI function. Blood in the stools is a sign that there might be some inflammation, some complications in the gut. And so obviously that would need to be investigated to see if that should be, again, a reason to be very cautious with feeding, or whether there needs to be some more X-ray study to verify that there's not any other complications. When premature babies are in the NICU and they are sick and need to have close monitoring of their oxygen and their CO2 to monitor their breathing, umbilical artery catheters are often placed. And one of the things that's associated with that is their location is in the aorta, and there could be possible interference with circulation, especially when we draw blood specimens from those catheters. So there is caution when they're in place. There needs to be monitoring that the baby has no signs or symptoms of complications. But different neonatal intensive care units have different policies as far as caution about how long after the UAC is removed should we wait before we start feeding the baby. Another condition that's associated with prematurity is patent ductus arteriosus. The patent ductus is, again, a vessel that's normally in utero, very important for circulation. But after birth, it's supposed to close, go away, so blood does not get shunted away from the lungs. So as a result, if that still continues because the baby is premature, sometimes there is a medication. And indomethacin is a medication that's given to close the ductus arteriosus. Well, unfortunately, it's not limited to just the ductus arteriosus. So sometimes the blood vessels that are delivering blood to and from the intestine are then going to be affected by that. So once again, it's another one of those clinical issues that needs to be considered as far as whether the baby is ready or able to tolerate feeding. And then anytime you need medications to improve cardiac output, which you see listed here, dopamine, a very common one, we have to worry again about the circulation to and from the intestine during the episode where the baby has decreased cardiac output. So in red, I have highlighted here that what you will hear mentioned in the NICU is that everything we're trying to do is to prevent the baby from developing necrotizing enterocolitis, which is often abbreviated NEC. This is an acquired disease that's characterized by inflammation of the bowel wall, followed by areas of necrosis or cell death, and most commonly in the terminal ileum, at that ileocecal valve at the proximal colon, but it could also affect any or all other parts of the small and large intestine. So one of the things that I think you can anticipate is when we talk about feeding, the clinicians, the nurses, the protocols will all be saying we want to be very cautious, very careful, because we want to prevent your baby, if possible, from developing NEC. So the clinical decisions have to do with when to start or initiate feeding. And I think you already heard me mention briefly that what we have are situations where the intestinal wall may have been injured, may not be able to tolerate feeding. So you have to take those factors into consideration about when to start or initiate feeding. But one of the things they have really tried to keep in mind is that, as I mentioned before, babies in utero are swallowing amniotic fluid. So if you have the baby nothing by mouth for extended periods of time, there's always the possibility that there will be a delay in the development of the GI tract, and some of those tissues that are used to being fed by the amniotic fluid are at risk to begin to have injury. The type of feeding, of course, we know that breast milk is the ideal feeding for a baby, and you've had last week already a presentation on achieving breastfeeding success with your preemie, and I think in the following week you will hear nutrition in the NICU and beyond that will also address this. So again, I think our challenge is when breast milk is not available is that we need to try to give the baby a premature formula that hopefully will come close to what the baby's nutritional needs are. But one of the challenges is that we don't have quite the perfect premature formula. Breast milk still has a lot of other properties that make it preferred. The method of feeding we're going to discuss in the next slide, so I'm going to skip on to the frequency of feeding. Things that have to be considered is whether this baby has the valvular function, the swallowing ability to tolerate intermittent feeding, whether the stomach is emptying properly, that intermittent feeding is better, or whether continuous feeding may be more appropriately tolerated by the baby. Concentration of the feeding. Breast milk, of course, is 20 calories per ounce. Basically, formula is 20 calories per ounce, the basic formula. But for premature babies, we usually have, because of their energy needs and their extra needs for growth, is that they need to have a higher caloric formula. The rate and amount of feeding is going to be determined by the stomach capacity. And as the baby is feeding, they will be measuring residuals. How much is still left in the stomach from the previous feeding? And so that will determine whether they can, again, continue to feed the baby the same amount, whether the baby is indicating that they're ready for an advancement of feeding, or whether the baby has significant residuals that maybe the feeding has to be discontinued. So the rate of advancement is going to be based on a lot of these factors. Very briefly, I just wanted to mention that there's a lot of research going on into issues of what is normal bacterial colonization of the GI tract. And you'll hear mention of good versus bad. And so, again, if this is an area of great interest, it's something you could read up on. But basically, there are probiotics that are being identified that are now even being given to babies in some clinical settings and are being studied. And basically what they're trying to do is to simulate the good immune properties and antibodies and all that the baby is getting through breast milk. The bad colonization, of course, are the organisms, many of them we call gram-negative, because they are bad and they cause infection, they secrete toxins, and if they are in the GI tract, then they can go through the tissues and get into the bloodstream and lead to systemic infections. So bacterial colonization of the GI tract is another important issue, that when babies are born, maybe they're already having infection issues, but while they're in the hospital, there's also the ability to acquire infection. So a lot of our NICU practices are to prevent that. And again, just to remind us that the baby has a very fragile intestinal lining. So when I talked about decreased blood flow, which is called ischemia, or when we talk about decreased oxygen carried by the blood to the intestine, that's called anaerobic metabolism. That can then lead to further tissue injury that can then add to complications of the GI tract. So let's talk a little bit about feeding. As I mentioned, again, obviously, and you know, the most common way and the best way is for babies to feed by nipple, ideally from the breast. But again, as an alternative, we have the bottle. But the baby has to be able to suck, swallow, and coordinate with breathing. So that's why until 32 to 34 weeks, we're not going to really be able to see the beginning of that coordination. And by 34 to 36 weeks, we hope that that would be more established. The stomach, of course, is where the feeding is going to first enter through the esophagus. And so if the baby is unable to suck and swallow and coordinate with breathing, we need to have a direct way to get the food into the stomach. So that would be the breast milk if the mother is pumping. It would be the premature formula if we're giving the baby formula. So tubes are passed either through the nose into the stomach or through the mouth into the stomach. So nasogastric tube or orogastric tube. There are some concerns, and there may be some variation in which of those two methods of gastric tube is better for the baby. When you put the tube through the nose, there is the possibility that you're reducing some of the baby's ability to breathe through their nose. So there could be some complication with breathing. So some babies, if they're very small and the feeding tube would take up too much space of one side of the nose, that may not be a recommended way. But we have feeding tubes that are very small so that the space that they take up can be less. But the smaller the tube, the slower the feeding will be going through the tube into the stomach. The orogastric tube is easier to place. The mouth is larger. But what people have found that if the baby is using the orogastric tube for many weeks, that they actually can develop what's called an oral aversion. In other words, when they are then able to progress to nipple feeding, when you put the nipple in the mouth, they may think something like an orogastric tube is being placed and really kind of have an aversion to that. So there is, again, different practice, different belief about whether or not orogastric tubes should be used over nasogastric. And some units actually will put the orogastric tube in and then after the feeding remove it and then put it in again for the next feeding, where other units find that that in and out procedure can cause irritation. So there are different practices depending upon your baby's response as well as what they have found to be possible complications. Babies who are having prolonged need for tube feedings, it might be that a gastrostomy tube would be placed in surgically, and then the baby could then have feeding directly into the stomach. But transpyloric feedings are something that I'd like to talk a little bit more about, because when babies are very premature, when they're unable to feed by mouth, and we want to feed them enough to simulate the amniotic fluid that they would have been swallowing, they have found that if we pass a tube through the stomach, through the pyloric valve, into the duodenum and into the small intestine, we could do what's called trophic feeding. So what this is just minimal, very small volume feeding. You see here less than 26 milliliters per kilogram of body weight per day for 1 to 5 days. What this would do is just kind of, like we say, kind of tickle the gut and still provide enough nutrition that would promote growth and development. it is not enough to provide all the baby's nutritional needs, so this baby would still have to be given what's called parenteral nutrition or IV nutrition. And commonly you'll hear it referred to in the NICU as TPN, total parental nutrition, or more commonly now PN, because we know that even though we're trying to provide them total IV nutrition, we have not yet been able to achieve that. So PN, or parenteral nutrition, may be what you hear more commonly now. The physiologic effects of the trophic feeding you see listed here is promoting gut mucosal development, maintain digestive absorptive GI functions because the baby is still using their gut, to stimulate intestinal motor activity and peristalsis, increase secretion of GI hormones and peptides, and maintain and stimulate immunologic and neuroendocrine functions. So hopefully this just, again, shows that we are now seeing that maybe this is the way when babies cannot eat large quantities, that this might help promote continuing development of the GI tract. So we talk about the requirements and the goals for adequate nutrition. This is a slide that I just tried to just bring up some of the issues that we're trying to achieve. One is the volume. The baby needs a certain amount of volume to meet their fluid needs as well as to provide the nutrients that are needed for growth and development. And so, again, as a preterm infant, about 100 to 150 milliliters per kilo per day would be our goal. So if that's continuous feeding, of course, they would divide it up over a continuous feed. If it's intermittent, you would see how they would decide, how much would be given with each feeding. We need to give the baby calories to meet their energy requirements. So in utero, the mother's amniotic fluid, was keeping the baby warm, and they really were able to move, but they weren't, again, very active. And they also, again, had no need to digest their food because of the fact that the IV nutrition had it in the right form. So babies need calories for energy to meet their metabolic needs, but also to grow. So 80 to 100 calories per kilo per day on average is what we're trying to achieve for growth, but that may vary with each baby depending upon the monitoring of their growth and development. When we talk about IV nutrition, we are giving the babies protein in the form of amino acids. When we are talking about breast milk or premature formula, whey and casein are the type of protein, and whey is the one that's more easily digested by the immature GI tract. Carbohydrate for IV is in the form of dextrose primarily, and again, with breast milk and premature formula, we have glucose polymers and, again, a little bit of lactose, but the lactase enzyme needed to break down the lactose is limited. So we give them a little bit to stimulate that development, but it has to already be in the form of glucose for it to be digested and for the baby to meet their glucose requirements. Fat is also very important. So lipids are given to premature babies intravenously. Some units started within the first 24 hours. Some might wait a little longer. But again, it's very important that babies get fats because many of the vitamins that the babies need are fat-soluble vitamins. And without adequate lipids, the baby won't be able to maintain their vitamin levels in their blood. Breast milk, of course, has very well-digested fat. And premature formula has MCT, medium-chain triglycerides, long-chain triglycerides, so that, again, the baby is able to hopefully get the fats that they need. One of the things that's very challenging in meeting the nutritional requirements for babies is vitamins. Vitamins are very sensitive. Some of them are fat-soluble. Some of them are light-sensitive. And the quantity of vitamins that they need is often difficult to give intravenously or in the protein or fat or carbohydrate or breast milk fortifiers that we are needing to give. So that is one of the challenges because there are lots of clinical conditions that babies born prematurely are predisposed to, such as retinopathy of prematurity, their immature retinal vessels, that they need to have vitamin A and E for those retinal vessels to develop properly so they won't have visual problems. We have to worry about calcium and vitamin D so their bones can develop. So these are really challenges that we have when we're trying to meet the nutritional requirements of the immature baby. And again, we're still working on that, but we've made a lot of progress, certainly over my career, in that we don't have babies with rickets, we don't have babies that are fracturing their bones just from normal handling, and we're having less complications with retinopathy of prematurity because we're doing much better with providing the vitamins and other nutrients that they need for growth and development. When we talk about progress, we're looking at growth. And so this is just on the next slide here to kind of show you that, again, there are goals of weight gain. We weigh the babies every day. And you see that when the babies are 24 to 32 weeks, we need them to grow a little more per kilo per day. As they get a little bit closer to term at 33 to 36 weeks, the rate, again, is a little slower. But this is what we find is necessary and achievable if we are able to provide them the nutrition that is adequate. The skeletal growth is monitored by the baby's length, and they actually have a special board called the Preemies length board that you place the baby on so that you can measure from crown to heel. And you see here what the rate of centimeters per week would be expected if the baby's skeletal growth is being achieved. The head circumference we measure, again, as an indication of brain growth. And again, we just use a paper tape measure, and you see that it's about 0.1 to 0.6 centimeters per week. Again, this will vary depending upon the baby's gestational age. And of course, we know that babies who are very premature are at risk for intraventricular hemorrhage. So with ultrasounds, we're able to verify that the increasing head circumference is normal brain growth versus perhaps some underlying intraventricular hemorrhage. Growth charts, again, are used to plot these measurements and to verify that they are meeting the normal goals of a premature baby. And we're glad that now we do have some premature infant growth charts, because prior to that we would be comparing the baby's growth to that of a term baby, and it's very different when they're preterm, because we're trying to simulate what the weight gain, what the length increase, what the head circumference would be if they were in utero. So we're trying to compare the fetus or similar gestation, not just very low to the low birth weight baby as they grow. So in conclusion, I hope that this provided you an update on the nutrients that are necessary for bodily functions and to achieve the growth and development of these babies, and how, again, it can be very challenging. The immaturity of the gut is one of the major challenges, and achieving the NICU period, referred to as being a feeder and a grower, is a very reassuring time to be in, but cannot be rushed, because we need to make sure that the baby is ready to tolerate the feeding and is able to tolerate the feeding and is able to grow at a rate that is safe. And this, again, is reassuring, but at the same time, we need to be very careful. So with this, I would like to stop, and I would welcome any questions, any comments. Thank you for this opportunity to speak with you.
Participants, if you have any questions, please go ahead and type them in the chat bar on your screen. Okay, if there are no questions, we will go ahead and end the session, but feel free to, I will be sending this presentation to all of you, so please feel free to reach out to Pebbles of Hope at info@pebblesofhope.org if you have any questions following this session and would like any further clarification on any of the things that you've seen and heard today.
Cheryl, before you end the call, can I ask you a question?
Sure.
I think all do the attendees know that you are a parent of a previously premature baby. Is there anything that you recall from your experience related to feeding and nutrition that, again, you would like to add or comment on, or being in that role, to just clarify?
Yeah, well, my son Nathan, he was very premature. He was a 24-week baby, and he actually did experience a bowel perforation a week after birth. And I can't stress enough, the importance of the breast milk. Unfortunately, because he was so small, he was unable to receive breast milk in the first week of his life. He just wasn't, able to process it. They tried to give him a couple of drops of the milk, but he wasn't moving anything through his gut. So unfortunately, he did develop a bowel perforation, and although it wasn't specifically classified as neck, it certainly related to that. And I think it was a similar issue in terms of, having limited oxygenation at birth and, an injury during the birth period that led to it. And, it certainly complicated his NICU stay following that, and made it difficult, and made it take a lot longer for him to get to a point where he could feed normally. The breast milk certainly has a lot of properties that could help prevent or at least reduce the incidence of NEC. It's extremely important for mothers to, do whatever possible to try to provide the breast milk for their babies. Of course, if that's not available, there are other options in terms of donor milk. There are premature formulas that are, improving in their proximity to breast milk. But, breast milk really, and especially breast milk from the mother, is really the best thing for preventing some of those complications.
Well, thank you for sharing that. I just, with the limited amount of time, there's just so much that, we'd like to say. But in one last closing remark, I kind of went back to one of my previous slides just to accentuate that one of the things I really didn't say initially was to achieve the calories, to achieve the nutrients, very often they have to concentrate the feeding. Even with breast milk, there are fortifiers, but especially with premature formula, and they have to increase the calorie content from not just 20 calories per ounce, but 22, 24, 28, even 30 calories per ounce. So as you are making this formula more concentrated and more hyperosmolar, as they call it, there is more risk that there could be tissue injury that could then, with the added of a feeding tube, could just increase some of these risks that you kind of initially highlighted that were part of your son's experience. So again, I just want to thanks for this opportunity. As a nurse who's been able to work with babies for over 40 years, I'm just very excited of the progress we've made. But I think, again, until we're able to prevent premature birth, we have to continue to work toward treatments for these babies so that when they do make it through that critical period, that they are able to have a normal life. So thank you again.
Thank you.